The following podcast is part of a certified educational activity titled Chairs Take, HER2-Targeted and Other Agents for Gastric Cancer. Access the entire activity and complete the post-test at peerview.com/GZH860. Downloadable slides and practice aids are also available.
Hello and welcome to Chairs Take, HER2-Targeted and Other Agents for Gastric Cancer. I'm Dr. David Ilsen from Memorial Sloan Kettering Cancer Center. During this presentation today, I will be providing a brief overview of recent developments on targeted therapies in gastric cancer, including the latest evidence presented at the 2020 Asco annual meeting, and helping to interpret what these data mean to our patients. Gastric cancer is the third leading cause of cancer globally, and we can see from this slide that geographic incidence varies tremendously. We see the highest relative incidence in Eastern Asia, Eastern Europe, and South America. But we can see that in North America, this is a relatively uncommon disease. Worldwide, over 1 million new cases will be diagnosed each year and 783,000 deaths. In the United States, we'll see nearly 28,000 new diagnoses annually with 11,000 deaths. Metastatic disease has a poor prognosis with a median overall survival of only 1 year. So when we treat advanced esophagogastric cancer, what's the optimal chemotherapy regimen to use? I always include this slide in my talks because it reviews across the board phase 3 trials from 2-drug and 3-drug regimens. On the right side of the slide, you see the data for the triplet DCF and ECF regimens with response rates in the 35 to 45% range. However, 2-drug regimens, particularly FOLFOX, FOLFIRI, and capecitabine platinum-based regimens, also have response rates in a similar range. And if we look across the board at time to tumor progression, it's virtually identical for these different regimens, and overall survival ranges from 9 to 10 months. Most patients are going to be best served with 2-drug chemotherapy, both in terms of effectiveness and survival outcomes. And recently from Japan, we had a pivotal trial which looked at triplet chemotherapy with S1 cisplatin and docetaxel versus doublet chemotherapy with S1 and cisplatin. And overall survival was the primary endpoint. This trial treated over 700 patients with advanced gastric cancer, and you can see clearly that the primary endpoint, overall survival, was no different for 2-drug versus 3-drug chemotherapy, and the hazard ratio on this trial was 0.99. To me, this is the most definitive evidence that 2-drug therapy should be the standard of care, both to optimize not only effectiveness but also patient tolerance. Now we have molecular classification of gastric cancer to try and get us beyond conventional chemotherapy alone, looking at molecular targets that we can exploit for new drug development. This is the breakdown from the U.S. Tumor Genome Atlas, where they studied 295 fresh frozen gastric and GE junction cancer biopsies, and they identified 4 subgroups that could be classified based on genomic profiling. The most common on the bottom was chromosomally unstable tumors. This accounted for 50% of gastric cancers and nearly 95% of GE junction cancers. Then the other less common subtypes included genomically stable cancers. This corresponds to the more diffuse subtype of gastric cancer, and this subtype is relatively genomically bland with very few, if any, targetable mutations. Then we have a significant percentage of MSI-high or microsatellite unstable tumors. In this series, it was 22%, but more realistically, it ranges from 5 to 10%. And then lastly, about 9 to 10% of gastric cancers are associated with Epstein-Barr virus infection. This shows the molecular features of the subtypes of gastric adenocarcinoma. EBV subtype, again, which is about 9 to 10%, has common presence of PIK3CA kinase mutations, but also a high expression of PD-L1 and PD-L2. MSI-high patients have a high mutation burden due to silencing of MLH1, and they also have relatively high rates of expression of PD-L1 and PD-L2. Both MSI-high and EBV-associated gastric cancers may be better candidates for immune checkpoint inhibitor therapy. As I said earlier, genomically stable tumors, which are more diffuse type gastric cancers, generally have a paucity of mutations. And then lastly, the most common subtype, chromosomally unstable gastric cancers, have a common presence of receptor-associated tyrosine kinase amplification, and most importantly, HER2, which is present in 24% of patients. What are the therapeutic implications of the molecular subtypes? Again, the MSI-high and Epstein-Barr virus-associated cancers may be good candidates for immune checkpoint inhibitor therapy. The genomically unstable tumors, again with the receptor-associated tyrosine kinase amplification, may be candidates for targeted therapies, but to date, HER2 is the only success. There have been failed trials targeting the MET pathway first line, as well as EGFR, not only in the first, but in the second and third line setting. And again, genomically stable tumors have not had clearly identifiable targets to develop new drugs to date. So let's shift the focus now to HER2-positive gastric cancer. HER2 expression in gastric and GE junction cancers is significant. Across the board, anywhere from 13 to 23% of these cancers are HER2 positive. We can see that intestinal cancers are more commonly HER2 positive, 15 to 34% compared to only 6 to 7% of diffuse gastric cancers. And again, GE junction cancers and esophageal adenocarcinomas have 25 to 35% rates of HER2 positivity compared to about 10 to 20% for more distal gastric cancers. HER2 is a key target in gastric cancer. Tristizumab was validated as an active drug in HER2-positive gastric cancer from the TOGA trial. This randomized trial showed clinical benefit in first-line therapy for combining trastuzumab with chemotherapy compared to chemotherapy alone, but a particular survival improvement for high expressors that were either IHC3+ or 2+ and FISH positive. In this subgroup of patients, which was 75% of patients treated on the trial, we achieved a 5-month improvement in median overall survival with the addition of trastuzumab. And this next slide again highlights on a forest plot that the subsets that benefit from the addition of trastuzumab to chemotherapy include the IHC3+ patients and the IHC2+ FISH positive. If we look at the bottom of the forest plot, we can see that if we're only FISH positive without IHC or IHC1+, that trastuzumab does not benefit, and that we do see survival benefits again for the 2+ FISH positive or for the IHC3+ subgroup of patients. So we know clearly from recent studies that esophagogastric cancer is not breast cancer. Drugs that are active in HER2-positive breast cancer in first and second line, unfortunately, are not similarly active in HER2-positive gastric cancer. One of the most disappointing trials was JACOB. This was a 780 patient first-line trial looking at capecitabine cisplatin alone, plus trastuzumab with or without the addition of pertuzumab, or dual-targeted therapy. Although there was a trend towards improved overall survival with dual-targeted therapy, at the end of the day, this was not a statistically significant difference with a hazard ratio of 0.84. Another negative trial was Heloise. This looked at a dose escalation of trastuzumab in 400 patients and did not demonstrate a benefit for a higher dose of trastuzumab. And then lastly, the LOGIC trial looked at capecitabine oxaliplatin with or without lapatinib, the tyrosine kinase inhibitor, in 545 patients, and this was also a negative trial with no difference in overall survival for lapatinib. We have seen recent very promising phase 2 data combining pembrolizumab, an immune checkpoint inhibitor, with trastuzumab and chemotherapy. This phase 2 trial administered either 5 or fewer capecitabine with cis or oxaliplatin plus trastuzumab with the addition of pembrolizumab. 37 patients were treated on this phase 2 trial and most received capecitabine oxaliplatin. The trial met the primary endpoint of improving 6-month progression-free survival, which was 75%. And overall, you can see that the median progression-free survival on the left was 13 months, with a rather striking median overall survival of 27 months. And you can see from the spider plot and the waterfall plot that the vast majority of patients responded to this regimen, 83%. Based on this very promising data for adding pembrolizumab to trastuzumab and chemotherapy, there is an ongoing phase 3 trial, Keynote 811, which is evaluating the addition of Pembrolizumab to first-line chemotherapy with Tristizumab in HER2-positive esophagogastric cancer. But again, esophagogastric cancer is not breast cancer. If we look at results from the second-line trials, giving lapatinib second line in the Titan trial, this was paclitaxel versus paclitaxel plus lapatinib. This did not show a survival benefit in 261 patients. And also the Gatsby trial. This looked at the promising drug TDM1 versus paclitaxel in second-line treatment, and TDM1 was no better than chemotherapy alone with paclitaxel in 412 patients. And then lastly, recently published in the JCO, was the TIAC trial. We always ask the question, does it help patients to continue Tristizumab into second-line treatment after they've progressed on first-line Tristizumab? This was a randomized phase 2 of paclitaxel alone, with or without Tristizumab, and it did not show any survival benefit for continuing Tristizumab into second-line treatment. So are there novel HER2-targeted strategies? One of the most important approaches has been the advent of antibody-drug conjugates, and we'll talk at length about Tristizumab deruxtecan, or DS-8201, which is a clearly active agent in HER2-positive gastric cancer. And there are ongoing trials of other agents, including RC48ADC, which is another antibody-drug conjugate looking at a combination with an antimicrotubule agent. Other monoclonal antibodies like margetuximab appear to be promising, in particular in combination with a PD-1 inhibitor. And now we have bispecific antibodies, including ZW25. This antibody targets two areas on HER2 and may potentially provide more effective blockade. And there are ongoing trials combining this agent with either chemotherapy or PD-1 inhibitors. And then we mentioned already promising data for combining immunotherapy with Tristizumab, and we have the ongoing KEYNOTE-811 trial, which is first line. So let's focus our discussion specifically on Tristizumab deruxtecan and look at its structure and mechanism of action. This is a promising antibody-drug conjugate, which combines an anti-HER2-targeted monoclonal antibody connected with a cleavable tetrapeptide linker to a chemotherapy payload, a topoisomerase I inhibitor. This looks at a payload with a different mechanism of action, and it's a high-potency payload. There is a very high drug-to-antibody ratio with this compound. Also interesting is once the antibody is internalized and the drug is released, it can have bystander effect. The chemotherapy payload can diffuse through cell membranes and affect neighboring cells. So indeed, what we can see potentially with this agent is bystander effect. Not only would HER2-positive cells be affected, but because the chemotherapy payload can diffuse out locally, it might potentially affect both HER2-positive and HER2-negative cancer cells in the same neighborhood. So phase 1 trial development was undertaken for this agent, and a recommended phase 2 dose of 6.4 milligram per kilogram was established. So what are the data for HER2-positive gastric cancer? A phase 1 expansion cohort treated 44 patients with Tristizumab deruxtecan, and we saw a rather striking 43% response rate. You can see this on the waterfall plot on the right, a significant rate of anti-tumor activity. As well, the duration of response was 7 months, which was rather striking, with a median progression-free survival of 5.6 months and a median survival of over a year. Toxicity was mainly hematologic, and there was a small rate of interstitial lung disease toxicity or pneumonitis of 2%. So this then led to the randomized phase 2 Destiny Gastric 01 trial, Tristizumab deruxtecan in advanced HER2-positive gastric cancer. This study was recently published by my colleague, Dr. Shitara, in the New England Journal of Medicine. Patients had to have progressed on previous Tristizumab-based chemotherapy and progressed on 2 or more previous chemotherapy regimens. Patients were then randomized 2-to-1 to physician's choice chemotherapy, which could either be irinotecan or paclitaxel, or the experimental treatment with Tristizumab deruxtecan given by IV infusion every 3 weeks. And we seem to duplicate the phase 1 experience with significant response. The unconfirmed response rate was 51% compared to 14% for physician's choice chemotherapy, and a centrally confirmed 43% response rate versus 12.5% for chemotherapy alone. Disease control was higher also at 86%, and the duration of confirmed response was 11 months compared to 4 months for chemotherapy. And we can see on the right, comparing the waterfall plots for Tristizumab deruxtecan versus physician's choice, that there was a significantly higher rate of anti-tumor response with this drug. Then if we look at overall survival, there clearly was a significant benefit, with a median overall survival of 12.5 months versus the control arm 8.4 months, with a hazard ratio of 0.59. Progression-free survival was also significantly improved, with a hazard ratio of 0.47. So what about safety of this new agent? Hematologic toxicity was significant, with a 50% rate of grade 3/4 neutropenia, but neutropenic fever was rare and occurred in single-digit percentages of patients. We did see nearly a 10% rate of interstitial lung disease or pneumonitis, but most of this was grade 1 or 2, and there were no grade 5 toxicities. So this is a toxicity that will need to be monitored carefully with this drug, but this is counterbalanced by the high degree of efficacy and improvement in progression-free and overall survival. There is now an ongoing phase 2 trial to duplicate these results in a Western population, and we are now studying in a phase 2 single-arm study Tristizumab deruxtecan in HER2-positive gastric cancer in patients that have progressed on one prior therapy with Tristizumab-containing chemotherapy. The primary endpoint is overall response rate, and this trial is actively recruiting in the United States. What about Rtog? This is a novel antibody construct which has an element targeting Tristizumab and also an element that may stimulate antibody-dependent cell-mediated cytotoxicity. We can see on the waterfall plot on the left that Rtog had a single-agent activity of 10%, which might potentially be enhanced with a combination of checkpoint inhibitors. Based on this, there is an emerging phase 3 trial which will look at Rtog in combination with checkpoint inhibitor versus chemotherapy in HER2-positive gastric and GE junction cancers. So what are my key takeaways from HER2-targeted therapies? Beyond Tristizumab, it is clear that HER2-targeted therapies have not been beneficial in patients with HER2-positive disease after progression on first-line Tristizumab. Several novel strategies, including antibody-drug conjugates, monoclonal antibodies, and immunotherapy combinations are being investigated. And I think the most promising, and what could lead to potential regulatory approval, is Tristizumab deruxtecan, which demonstrated substantial and clinically meaningful improvements in response rate and survival compared to standard chemotherapy in the phase 2 randomized Destiny Gastric-01 trial. The positive results suggest that antibody-drug conjugates may become a new treatment standard for patients who have been previously treated. So what about neoadjuvant therapy? I'm going to present now data from 2 neoadjuvant trials that were presented at Asco 2020. One of the most anxiously awaited trials was Rtog 1010. This studied patients that were HER2 positive with esophageal and GE junction cancer. Patients were treated with standard chemoradiation followed by surgery with carboplatin paclitaxel and radiation, with or without the addition of Tristizumab. Another important study presented, which was a smaller randomized phase 2 trial, was Petrarca, which was in GE junction and gastric cancers, looking at perioperative chemotherapy alone. This trial looked at the flat regimen with or without dual targeted HER2 therapy, adding Tristizumab plus Pertuzumab to perioperative chemotherapy in gastric and GE junction cancers. So what were the results from the Energy Oncology Rtog 1010 trial? Again, this evaluated Tristizumab plus trimodality therapy in HER2 overexpressing esophageal and GE junction adenocarcinomas. Patients had to have either node-positive disease or T2-3 disease which could be surgically resectable. And HER2 status was confirmed centrally, and patients had to either be IHC3 plus positive or FISH positive. 203 patients were randomized 1-to-1 to standard chemoradiation followed by surgery, which again was carboplatin paclitaxel and radiation, with or without the addition of Tristizumab, both given during chemoradiation and then as adjuvant therapy after surgery for 13 treatments every 3 weeks. Unfortunately, this was a negative trial. The primary endpoint was disease-free survival, and we can see on the left that although there was a slight separation of the curves in the middle, at the end of the day there was no statistically significant improvement in disease-free survival for adding Tristizumab to chemoradiation compared to chemoradiation alone, with a median disease-free survival of 19.6 months versus 14.2 months for chemoradiation, with a hazard ratio of 0.97. Overall survival also showed no benefit for the addition of Tristizumab, where here the hazard ratio was also near 1, with a median overall survival for chemoradiation alone of 38.9 months versus 38.5 months for the addition of Tristizumab. So what do we learn from this study? I think that moving forward, Tristizumab alone will not be an adequate strategy to develop in the adjuvant or neoadjuvant treatment of esophagogastric cancer. It's simply not enough. What about surgery and pathologic outcome from the Rtog 1010 study? Similar numbers of patients went to surgery, whether or not they got Tristizumab, 84% versus 81%, and there was also no difference in pathologic complete response rate with or without Tristizumab, which ranged from 27 to 29%. So what about the Petrarca trial? This was a study done in Germany, studying HER2-positive GE junction and gastric adenocarcinomas. Patients were randomized to receive standard perioperative FLOT chemotherapy before and after surgery, with or without the addition of dual-targeted HER2 therapy, combining Tristizumab with Pertuzumab, not only during chemotherapy, but also as additional adjuvant treatment for 9 cycles after surgery. Again, this was a small randomized phase 2 trial, and so we only treated 81 patients. It does appear, however, that there was significant downstaging with more T1 patients. There were more node-negative patients receiving HER2-targeted therapy, 68% versus 39%, and the pathologic complete response rate was increased from 12 to 35%. So there is a signal from this study that we may enhance response with dual-targeted HER2 therapy combined with the FLOT regimen. It's difficult to interpret disease-free and overall survival, but the trends do suggest a benefit. Whether or not this is going to move forward in phase 3 is a bit complicated because we did see negative results for Pertuzumab in the advanced disease study, but this trial does provide a signal that may indicate that further study of dual-targeted therapy is warranted, particularly given the lack of success for Tristizumab alone in the Rtog trial. So I'm going to mention briefly anti-angiogenesis agents in gastric cancer. Ramucirumab plus paclitaxel and ramucirumab alone are approved as standard second line. These guidelines recently were amended to permit the use of FOLFIRI plus ramucirumab second line, given the increased usage of the FLOT regimen, which gives patients a taxane up front. We now have some supportive data for FOLFIRI with ramucirumab from a randomized phase 2 trial from Germany. This looked at FOLFIRI plus ramucirumab versus paclitaxel plus ramucirumab as second-line treatment in advanced esophagogastric cancer. We see similar rates of overall survival with the two approaches, but more importantly, almost 75% of the patients on this trial had prior docetaxel exposure, and there was an observation on this trial that the patients that had previous docetaxel exposure may have had an improved progression-free survival, a better response rate, and a potentially numerically longer overall survival for the combination of FOLFIRI plus ramucirumab versus paclitaxel plus ramucirumab. So use of FOLFIRI ramucirumab might be a consideration in a patient that has received recent prior taxane-based chemotherapy. What about immunotherapy? This gets a little bit more complicated, but I would argue that much of the results to date have been negative for checkpoint inhibitors in esophagogastric cancer. This slide overviews recent trial results. If we look at single-agent activity in refractory gastric cancer, the KEYNOTE-59 trial was a large phase 2 expansion cohort trial of Pembrolizumab in previously treated GE junction and gastric cancer. Patients that were PD-L1 positive had a response rate of about 10 to 12% and suggestion of median survival prolongation. Particularly striking were the results in MSI-high patients with a response rate exceeding 50 to 60%. Based on KEYNOTE-59, Pembrolizumab was approved as a single agent in chemotherapy refractory GE junction and gastric cancers if patients were MSI-high or PD-L1 positive. The other positive study was ATTRACTION from Japan. This was a randomized phase 3 trial comparing nivolumab versus best supportive care in chemorefractory gastric cancer with a response rate of about 11% and a 1-year survival of 20% for nivolumab. This drug is now approved in Japan irrespective of PD-L1 status. The JAVELIN Gastric 300 trial, however, was negative. This was a third-line trial of avelumab versus physician choice, and this did not show superiority for avelumab over third-line chemotherapy. What about second-line chemotherapy? KEYNOTE-61 was a head-to-head comparison of pembrolizumab versus paclitaxel in PD-L1 positive adenocarcinoma. This was a negative trial. It did not show superiority for pembrolizumab over paclitaxel, and also arguably used an inferior chemotherapy control arm. We should have really considered using paclitaxel ramucirumab and not paclitaxel alone. And then lastly, first-line trials, KEYNOTE-62. This was first-line checkpoint inhibitor therapy with or without chemotherapy. This also was a negative trial for the primary overall endpoints. We can debate the non-inferiority question, but overall we'll discuss essentially negative results for first-line use of pembrolizumab in GE junction and gastric adenocarcinoma. And more recently, the JAVELIN trial, Gastric 100, treated patients with first-line chemotherapy, and then they were randomized to maintenance avelumab or to continue chemotherapy. Avelumab was not superior to maintenance chemotherapy, so this was also a negative trial. I want to focus a little bit now on KEYNOTE-62. This is the first-line pembrolizumab trial. This is the data results for pembrolizumab plus chemotherapy versus chemotherapy alone, again in all patients that were CPS positive 1% or higher. You can see the negative outcome here. There was no difference in 12-month median overall survival, and there was a slight trend of 5% at 2 years, but the hazard ratio was 0.85. So adding pembrolizumab to first-line chemotherapy is no better than chemotherapy alone. A similar observation in CPS 10 patients. Pembrolizumab plus chemotherapy was no better than chemotherapy alone, with essentially no significant differences in 12-month median overall survival and a 6% difference at 24 months. The take-home message: we should not combine pembrolizumab with chemotherapy first line. It is not better than chemotherapy alone, even in PD-L1 positive patients. So what about the question of pembrolizumab versus chemotherapy? If we look at the PD-L1 or CPS 1% of patients, there was no difference in 12-month median overall survival of 47%, but the curves do start to separate later. The problem, however, is the left side of the curve. The death rate with pembrolizumab alone was 10% or more higher during the first 12 months. More patients were dying of their cancer with pembrolizumab alone compared to chemotherapy. The results were a little better with CPS 10 or PD-L1 10% patients. Again, there was no difference in 12-month median overall survival, but a more robust plateau later, with a near 17% improvement in 24-month median overall survival. But again, if we look at the left side of the curve, there was a higher death rate in patients getting upfront pembrolizumab. And the late separation of the curves is not surprising, because we know that pembrolizumab helps a small subset of patients later and not earlier. These results do not change practice and use of pembrolizumab in PD-L1 positive patients in later line but not first line treatment. The other concern is rapid progression on pembrolizumab. If we look at both the CPS 1 and 10% patients, this is progression-free survival, and you can see that in both of these subgroups, the majority of patients progress rapidly on pembrolizumab. PFS is arguably better with initial chemotherapy compared to pembrolizumab. And the worry is, and again, given the higher death rates, is that you can't salvage these patients with chemotherapy later. So what about Keynote-61? This is Pembrolizumab in the second-line setting. Again, this was overall a negative trial. Certainly, if you're PD-L1 or CPS negative, median overall survival was inferior for Pembrolizumab. For PD-L1 1% or CPS 1% of patients, again, there was a trend towards a higher earlier death rate, but then the curves separate beyond 6 months. And for the CPS 10% or PD-L1 10%, the separation is more robust later, but again argues a late benefit for Pembrolizumab. It is not superior within the first 6 to 8 months of treatment. It does indicate, however, that perhaps in the CPS 10% of patients, this drug is more active. So what about the updates for ASCO 2020? The Keynote-61 trial was updated in Abstract 4503 with long-term follow-up of second-line Pembrolizumab. They pretty much came up with the same observations. We do see this late separation of the survival curves, particularly in patients that have the CPS 10% positive rate, and it did lead to fewer drug-related adverse events. I think more interesting from ASCO was the observation that there was an association between tumor mutational burden and benefit from Pembrolizumab. However, high tumor mutational burden was only observed in a small minority of patients, and it's not clear if this measure adds anything beyond measuring PD-L1 or CPS scores. Then I want to mention another novel agent, Zolbetuximab, that is in ongoing phase 3 trials. Zolbetuximab is a chimeric antibody which targets the Claudin 18.2 protein, which is a gap junction protein overexpressed in about 70% of gastric cancers. The FAST trial was a randomized phase 2 trial of EOX chemotherapy with or without Zolbetuximab in Claudin 18.2 positive patients. In the total population, you saw about a 5-month improvement in overall survival adding Zolbetuximab, and in the high expressors of Claudin 18.2, which was about 30%, we saw a 7-month improvement in median survival. Based on these encouraging results, there are 2 ongoing phase 3 trials. The phase 3 trial Spotlight is FOLFOX plus or minus Zolbetuximab, and then there's also an ongoing phase 3 trial, the GLOW trial, which is capecitabine oxaliplatin with or without Zolbetuximab. So what are my key takeaways from this discussion today? Evaluating novel strategies with targeted therapies. Tristizumab alone failed to improve any endpoint in esophageal and GE junction cancers when combined with chemoradiotherapy and surgery. Clearly, we need to do more than just Tristizumab alone. Combination targeted HER2 therapy will need to be studied, and we have some promising early results for dual targeted HER2 therapy. There may be a potential role for including immunotherapy agents and novel HER2 targeted agents. Trastuzumab deruxtecan is a significantly active new agent after prior trastuzumab-based therapy. New combinations of chemotherapy with ramucirumab have shown promise, particularly FOLFIRI plus ramucirumab in the setting of previous recent taxane exposure. While Pembrolizumab is approved in the third-line setting, immune checkpoint inhibitors have shown modest activity in early-line setting and certainly have not achieved an indication to be combined with chemotherapy or replace chemotherapy in the first or second line. The exception, however, is MSI-high cancers in which checkpoint inhibitors have a high degree of response, progression-free and overall survival, and we can consider earlier line use of these drugs in MSI-high cancers. New combinations with immune checkpoint inhibitors are promising, and new targets and therapy strategies are ongoing and under investigation. Thank you very much.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/GZH860. This activity is supported by independent educational grants from AstraZeneca and Daiichi Sankyo Incorporated. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peer Review Institute for Medical Education.